My name is Chris Thrappleton. It's my privilege to be able to chair the next session with my colleague, Professor Emma Baker. So this is to honour the life and career of Professor Sir Colin Dollery. So over to Emma to introduce the first speaker.
Thanks very much, Chris. I'm Emma Baker. I'm currently the Clinical Vice President of the British Pharmacological Society. We're particularly delighted to have Diana and Colin Dollery's family in the audience. It's a great honour for Chris and I to chair this session. The first speaker is Peter Barnes. Those of you who know Peter well will know that he's an eminent respiratory scientist and highly cited. But what you might not know is that at the beginning of his career, he worked in the lab with Colin Dollery. Over to you, Peter.
Well, thank you, Emma, and thank you very much for inviting me to participate in this symposium about Colin. It's a great honour to do so, and I'm very glad to see Diana is able to come. I was a clinical research fellow for Colin in 1978, so that's a long time ago, and after that I went on to specialise in respiratory medicine. So these are my potential conflicts of interest, which I know no one else seems to show, but they're not important. The outline of my presentation is shown on this slide. So although Colin is a giant of clinical pharmacology and is known particularly for cardiovascular pharmacology and the treatment of hypertension, he also made very significant contributions to lung research and published over 50 peer-review papers on this topic. So I'm going to talk about some of the areas that Colin was working on in lung research and respiratory pharmacology, starting with his early work on radiolabeled gases, and then lungs as metabolic organs, the production of lipid mediators by lung tissue, the role of catecholamines in asthma, and lung adrenoceptors. So I'm going to start with his early work on radio-labeled gases. It's Colin calling. So he was working at the Hammersmith Hospital with Philip Hugh Jones. Philip was the illegitimate son of Philip Morell, who was the husband of Lady Ottoline Morell. So he was linked to the Bloomsbury set and was a very distinguished respiratory physiologist. John West was an Australian who came to work at Hammersmith and subsequently went back to San Diego, where he became the most famous respiratory physiologist in the world. And John is someone I still see from time to time. So Philip and John were working with Colin on the inhalation of radioactive gases, and that was because at the Hammersmith site, the MRC had installed a cyclotron that was able to generate radio-labeled molecules with short half-lives, and that included oxygen-15 with a half-life of around 2 minutes. And it was possible to make radio-labeled oxygen, carbon monoxide, and carbon dioxide. And the subjects would sit in and breathe the radioactive gas with tidal breathing. And you can see in this old photograph that radioactivity counters were placed over the chest. And for the first time, this was able to give regional lung function. And you can see that with inhaled CO2 in a normal subject, there's a difference in the ventilation of the upper lobe and the lower lobes, so there's better ventilation to the lower lobes. And they went on to show that this ventilation was impaired in various lung diseases like emphysema and cardiac diseases. But there's a real problem in using isotopes with such a short half-life because you can't really do very much. So they went on to a longer-lived isotope of xenon, xenon 133, which has a half-life of around 5 days. And the great advantage of xenon is that it could be inhaled as a gas, but also dissolved in saline and injected. So it was possible to measure both ventilation and perfusion and to work out the VQ ratio. And here you can see again the difference between the lower lobes, which are better ventilated and better perfused, and the upper lobes. And it was possible to show disturbances in this VQ ratio. And what they showed, which is a really important discovery, is that this VQ mismatch accounts for systemic hypoxia in emphysema. And VQ scans are still used in clinical practice, although with different isotopes. So this was really important formative work for something that has become extremely important in the diagnosis of certain lung conditions such as pulmonary embolism. So the next area that Colin looked at was metabolism of drugs and molecules by the lung. And the idea is that lungs may metabolize inhaled drugs, but also systemic drugs, since the whole of the cardiac circulation goes through the lung. And this could be studied with a preparation called the isolated ventilated perfused lung preparation. And the main subjects were the ones that lost the races at White City Greyhound track. And what they were able to do was look at what happened with inhaled drugs in terms of absorption across the lung into the circulation. For example, with isoprenaline, which was commonly used as a bronchodilator for asthma in those times, you can see that isoprenaline is rapidly absorbed into the lung circulation and has a very small metabolism in the lung. And this was due to COMT in the lung, but there was no monoamine oxidase activity. But when terbutaline was used, which is a catecholamine that was substituted, so resistant to these enzymes, there was no metabolism in the lung, and it was also absorbed into the circulation. So with inhaled isoprenaline, a small fraction was converted to the metabolite of COMT enzyme activity, and similar results were found in humans. And what they found is that after inhalation, the metabolism was very similar to the metabolism of isoprenaline when it was given systemically. So the conclusion, which was correct, was that most of the inhaled drug was actually swallowed and absorbed into the systemic circulation from the gut. And that has continued to be the case with all inhaled drugs. They also looked at other drugs in the lung. So nicotine was metabolized to cotinine, which is still used as a stable marker of cigarette smoke exposure. They also looked at cannabis. For some reason, they gave this by perfusion, which is not the normal route of delivery, I understand. And they looked at propranolol, which was not metabolized by the lung. So these were very important early studies on the lung as a metabolic organ. Lungs also produce mediators, and Chris Hensby joined the department and set up a GCMS assay for prostanoids and their metabolites. And in perfused dog lungs, we found that a major product was prostacyclin, which had recently been described by Salvador Moncada and John Vane, and its major metabolite, which is 6-oxo-PGF1 alpha. Luckily, I was unable to find this publication, and it has never been cited. The reason I say that is that it has very traumatic memories for me. I used to have to set up this awful preparation, which took a whole day, and then Colin would appear in his surgical scrubs and inject the substance into the preparation, which in this experiment was tritiated arachidonic acid. And then after this injection, he would tell me to release the clip. But I was so frightened by Colin, I panicked and released the wrong clip. And the pressure built up, and Colin was completely covered in greyhound blood. So I was moved off the isolated lung preparation and went on to human studies, which actually turned out to be much easier than the isolated dog lung preparation, because you could measure the concentration of mediators and drugs across the lung by sampling simultaneously from the pulmonary artery and the left ventricle. And we did that for 6-oxo-PGF1 alpha, and you can see that the lung is secreting prostacyclin into the systemic circulation. So this prostaglandin is acting as a sort of anticoagulant that feeds into the systemic circulation. Interestingly, there was a patient on oral contraceptives that didn't produce any prostacyclin, so we wondered if that might be a mechanism for increasing risk of thrombosis. Now, I was a general medical registrar at UCH in 1978, and I couldn't find another job. I went to endless interviews and failed them all, and they would be in quite random subjects like cardiology, gastroenterology, endocrinology, because I wanted to be a general physician. But one job I applied for was a senior registrar post in respiratory medicine at the Hammersmith, and Neil Pride, a wonderful man, was the head of respiratory medicine at the Hammersmith at that time. And as usual, I didn't get the job, but Neil rang me at home and said, you need to do some research if you're going to get a senior registrar job. And I said, I really don't want to waste my time doing that. He said, I know Colin Dollery is looking for a research fellow to work on lung pharmacology. And this is supported by an MRC program grant, which was known as the Lung Grant. So then I joined Colin's department. And at the same time, Maurice Brown had joined the department. Maurice went on to become the first professor of clinical pharmacology in Cambridge. And he set up a sensitive radioenzymatic assay for circulating catecholamines. And although people talk a lot in the general parlance about adrenaline in the circulation, no one had ever been able to measure it because the concentrations were too low. So there was a good rationale for measuring adrenaline in asthma. Firstly, there's no sympathetic innervation of human airways, surprisingly, suggesting that circulating adrenaline may be the important regulator of lung beta adrenoceptors. And this may be important because when you give beta blockers to asthmatics, they get bronchoconstriction, whereas normal people don't, suggesting that the adrenaline might be very important. There had been no previous studies on catecholamines in asthma, and yet adrenaline had been used to treat asthma since 1903. So with Maurice's assay, we looked at adrenaline concentrations and found there was no difference between asthmatic and normal people, nor with noradrenaline. We had expected that people with asthma would have higher adrenaline because they had bronchoconstriction and it would be a way to overcome this problem, but this was not the case. So we went on to study exercise-induced asthma because exercise is known to increase circulating catecholamines. So we took people with mild asthma and exercised them on a treadmill and they get a small increase in lung function during exercise, that when they stop exercising, they get a marked fall in lung function, which is exercise-induced bronchoconstriction. Normal people don't show any change in lung function. And normal people show a rise in adrenaline and noradrenaline, but what was really surprising was that in asthmatic people, the catecholamine rise on exercise was markedly blunted. And that may be one of the reasons they get bronchoconstriction, because they're not getting adrenaline to stop that happening. But this was a surprising observation. We know that exercise induces bronchoconstriction in asthma through hyperventilation, which dries out the airways and activates mast cells to release bronchoconstrictors. So we gave matched isocapnic hyperventilation to mimic the degree of exercise-induced asthma that we saw with the exercise challenge, and there was no increase in catecholamine. So even when they get marked bronchoconstriction, they're not increasing their adrenaline concentrations. And even in acute exacerbations, there's no increase in adrenaline. But we could increase adrenaline in people with asthma if we made them hypoglycemic with insulin, because we had thought the adrenal medulla may have been exhausted of adrenaline, but you can stimulate it, and maybe this is through a different pathway. We still don't understand this mechanism, and it's the mechanism of this observation in asthma, and it's been confirmed in several subsequent studies, so it probably is right. But we think adrenaline may play a key role in nocturnal asthma. Many people with asthma wake in the early hours of the morning, and this is due to a circadian rhythm in lung function, which is an exaggeration of the normal pattern. So the highest value is at 4 in the afternoon, and the lowest value at 4 in the morning. And this very closely mimicked the pattern of plasma adrenaline concentration. And you can see that asthmatics had the same pattern as normal. So we thought that this dip in adrenaline at night may be why they're getting bronchoconstriction at night and waking up. And these studies were done with Garrett Fitzgerald, who, as you know, is now a very famous cardiovascular pharmacologist, and Garrett is working in Philadelphia at the moment. So as a separate experiment, we looked at infusion of adrenaline. And what you can see is that with a very low concentration of adrenaline infusion at 4 a.m., these were terrible experiments to do, because we had to sleep on little beds next to the patients so we could get up and take these samples and try not to wake them up. So very low concentration of adrenaline that eliminated the circadian flow completely prevented this nocturnal dip in lung function. So adrenaline does have an important role in asthma. About this time, I moved on to become eventually I got the senior registrar job in respiratory medicine at Hammersmith. So it was right, doing some research helped me get the senior registrar post. And I was followed by Philip Ind, and he and I worked with Morris, who just developed a new assay to measure histamine in the circulation, which had not previously been possible. So this is a similar type of assay to the catecholamine assay. And what we found is that there was an increase in histamine in people with asthma, whether it was allergic or non-allergic asthma. And we found it was increased at 4 a.m. when the adrenaline was at its lowest. So that suggested that the fall in adrenaline may reduce the beta stimulation of mast cells to lead to this increase in histamine, which then causes the nocturnal bronchoconstriction. And we know that beta blockers can induce bronchoconstriction in people with asthma. So we did this study. I don't know what the ethics committee would say now about this, but we infused asthmatics with propranolol. and they got bronchoconstriction, as we hoped, but normals didn't. And what Philip found is that the ones that got bronchoconstriction also showed an increase in plasma histamine, whereas the ones that didn't respond to propranolol didn't show any such change. So the idea is that mast cells have beta receptors, which normally tonically inhibit the release because of endogenous adrenaline. And so if you give beta blockers, you stop the tonic inhibition of mast cells, leading to the release of bronchoconstrictor mediators. Now, there was a very influential hypothesis proposed in 1968 by Andor Sentivani that asthma was due to an imbalance between alpha receptors, which are bronchoconstrictor, and beta receptors, which are bronchodilator. And it was a very popular hypothesis that led to a huge amount of research, much of which confirmed this hypothesis in animals and humans. And following this hypothesis, Matt Connolly and Kathy Greenacre, who were working in Colin's department at that time, decided to look at beta receptor function in asthmatic patients. And they did this by measuring isoprenaline-induced cyclic AMP response in circulating lymphocytes, and found that asthmatics had a markedly blunted response. But this may have been desensitization of beta receptors due to the sympathomimetic bronchodilators that they were all taking. And when they were switched to non-adrenergic therapy, you can see that beta receptor function completely recovered. And so the conclusion was that beta receptor function is normal in asthma, at least in lymphocytes, but lymphocytes are not the lung. So we needed to know what was happening to adrenoceptors in the lung. And about the same time that I started in Colin's department, a cardiologist from San Diego, Joel Carliner, who I still occasionally see, joined the department, and he was interested in adrenergic receptors in the heart, and I was interested in the same receptors in the lung, so we could collaborate together very productively. And we used a new technique, it was new at the time, called radioligand binding, using radiolabeled adrenergic antagonists to mark the beta receptors in the lung. Colin said that this was far too difficult for us to do, which is a great encouragement, so we did it, and actually published quite a lot of papers on this. And with John McDermott, who was also just joining the department, a lot of people were joining the department then. John was working in the NIH and came back to the UK. And we had a guinea pig model of asthma, which was guinea pigs that were sensitized and then exposed to ovalbumin, and they get wheezy. And we took the lungs from these guinea pigs and showed that they had increased numbers of alpha receptors and decreased numbers of beta receptors. So this exactly confirmed Sentivani's hypothesis. So we thought that in human asthma, there may be an increase in alpha adrenergic bronchoconstrictor mechanisms, and therefore that alpha blockers would be a potential treatment. So we gave the alpha blocker prazosin by inhalation to people with asthma, and disappointingly, there was no improvement at all. There was a small reduction in exercise-induced asthma, but this may be a cardiovascular effect. We then went on to study these receptors in human lungs, which were obtained at surgical resection, mainly in smokers who had lung cancer. And what we showed is that beta receptors and alpha receptors were present. There were more alpha receptors in human lung than guinea pig lung. And the beta receptors were beta-2 receptors, and the alpha receptors were alpha-1 receptors. This was done in lung homogenates, so we don't know which cells carry these receptors. So we then wanted to try and localize beta receptors. And we used a new technique that has just been described by someone called Daphne Atlas, who was a neuroscientist in Israel, and she'd used a fluorescent analog of propranolol to bind to beta receptors, and then showed fluorescence on cells and organs where she claimed that beta receptors were located. So we got hold of this fluorescent marker of beta receptors and showed that it did bind to beta receptors in the lung. And we gave it intravenously to rats. And we found that many things in the lung fluoresced, so we were very excited. But none of the fluorescence was removed by an excess of propranolol, meaning that it was non-specific fluorescence. In fact, autofluorescence, largely due to lipofuscin, which accumulates with age. So this was extremely disappointing. And at that time, I got an MRC traveling fellowship to go to the Cardiovascular Research Institute in San Francisco, where I worked with Carol Basbaum, who is a brilliant anatomist. And we used lung sections and autoradiography to localize where the beta receptors might be. And what we showed is that there's a high density of beta receptors in small airways of the lung, both in epithelial cells and in the muscle, but also in the alveolar walls. And the high density of beta receptors in human lungs is due to the very high labeling of the alveolar walls in the lung. Actually, these beta receptors were unexpected in that place, but we now know that they're important for keeping the lungs dry. They pump fluid out of the lung back into the circulation. So we were able to look at peripheral lung and also large airways, where you can see that we could detect labeling of airway epithelium, smooth muscle, and a submucosal gland that secretes mucus into the airway. So after I'd gone on to do clinical work at the Hammersmith, the lung research continued with Rick Fuller, who then replaced Philip Ind, who had replaced me. And I think I was a consultant by then. And Ian Blair was a really good analyst who set up GCMS assays for leukotrienes. And later on, Graham Taylor developed an easier assay with HPLC and radioimmunoassay. And what they showed is that leukotrienes were major mediators released from the lung after allergen challenge. And leukotrienes were known to be potent bronchoconstrictors in normal people and asthmatics. And Graham was able to develop an assay that could detect cystinoid leukotrienes in the urine. LTE4 is the most stable cystinoid leukotriene. And what they showed is an increase in people with asthma exposed to allergen. And you can see the levels come down after allergen challenge, showing that allergen-induced bronchoconstriction is due, at least in part, to cystinoid leukotrienes, which were also increased in acute asthma. And that suggested that leukotriene antagonists might be a useful treatment for asthma. And one of the first ones that developed is called Tomileucast. But it turned out not to be a very good drug because it had poor pharmacokinetics. But Rick Fuller did show that it reduced responses to inhaled and intradermal allergen in atopic subjects. So Leucast was a much better leukotriene antagonist. It blocks cis-LT1 receptors and was introduced into clinical practice. It was shown that in Colin's group that it reduced allergen-induced bronchoconstriction and airway hyperreactivity, and inhaled Leucast was able to reduce the early but not the late response. Actually, we don't use leukotriene antagonists anymore because they're much less effective than other treatments. So Colin made major contributions to our understanding of the lungs, and that's probably overlooked because his contributions in cardiovascular pharmacology were so great. But his important early work on lung ventilation laid the foundations for ventilation perfusion scans that are used today. His research led to an understanding that lungs play a metabolic role in transforming some drugs and not others, and that inhaled drugs are rapidly absorbed into the circulation. He looked at the production of lipid mediators, particularly prostanoids and leukotrienes by lung, especially in people with asthma. The research that I was involved in looked at the role for the first time of circulating catecholamines in asthma and then lung ADRENOCEPTORS by direct binding. I learned an enormous amount from Colin. He was a brilliant researcher. He taught me about the importance of translational medicine, and I think all of us owe him a great debt of gratitude. It's quite extraordinary how many professors of clinical pharmacology were trained by Colin. So I'm very pleased, Diana, that you're able to hear these tributes to Colin's enormous contributions to medicine. Thank you.
Thanks very much, Peter, for painting that amazing picture of this vibrant department of melting pot of ideas orchestrated by Colin, creating all the received knowledge that we have today. Does anybody have any questions for Peter? Or anybody online, feel free to type your question. Diana, please.
It's not a question, but I'm really pleased to have that lecture on his lung work, because so many people, as Peter has said, usually remember him for the work on hypertension and drugs and things like that. But it was a very important part of his research, and I'm just so happy to hear that work expressed so well by Peter. Thank you.
Thank you for that. Would anyone else like to ask a question? While you're thinking, I was very struck by your human experiment, sampling simultaneously the pulmonary artery and the left ventricle in a woman on an oral contraceptive. And also, I wondered about the sort of experimental medicine at the time in volunteers. Were you experimenting on yourself? How was that regulated? What was that like in the 70s?
Well, I think these were people undergoing catheterization that we happened to get the blood from. Actually, I'd completely forgotten I'd ever done that experiment, but I found it when I was searching PubMed. But we did experiment on ourselves. So the beta blocker stuff was done on ourselves and asthmatic friends, and Colin ran a very strict clinical pharmacology lab, so you actually had to book quite a long time ahead to do experiments, which was a great discipline. So we actually learned a lot from the very precise way of undertaking these studies in a very controlled environment.
Brilliant. Any other questions? I think if there's no other questions, a great thank you again, Peter, for a great talk.